Good morning, good afternoon, good evening. Thanks very much for joining us for this webinar of the Working Party in Quality and Safety. My name is Jose Maria Chema Valderas. I'm the Working Party Chairman, and it gives me great pleasure to be hosting this seminar, Advancing Patient Engagement and Partnership from Social Prescribing to Advocacy Across the Healthcare Cluster. And it gives me also particular pleasure because we have very esteemed colleagues from Singapore who will be presenting their experiences and in terms of patient engagement and partnership. We have with us Professor Tan Kok Kian, Group Director and Senior Associate Dean at SingHealth, Duke NUS Institute for Patient Safety and Quality, Senior Consultant in Maternal and Fetal Medicine in KK Women's and Children Hospital in Singapore. We also have Ms. Joy Tan, Head Coordinator of the ESTHER Network in Singapore and Person-Centered Care at the Division of Population Health and Integrated Care in Singapore General Hospital, and Senior Principal Physiotherapist at SHGG Department of Physiotherapy. And we also have Mr. Elil Matiyan Lakshmanan, Mentor and Co-Chair Designate, the SingHealth Patient Advocacy Network, SPAN, Co-Founder and President of the Ostomy Association of Singapore, and the Interim Vice President of the Asia South Pacific Ostomy Association. All these institutions will make a lot more sense during the presentation. We will have a 40-45 minutes presentation, and then we will save 15 minutes for a questions and answer session. And without further ado, please, Professor Tan, I'm hand over to you, please.
Thank you, Chairperson. Hi, everyone. I'm very happy to be here speaking on this topic, which we are very interested in, and it is a good thing to be able to do this for our healthcare system. So my topic is on advancing patient engagement and partnership, looking at social prescribing to advocacy across the whole healthcare cluster. Next. So in terms of disclosure, I do not have any relevant financial or commercial interests. I helped initiate the SingHealth Patient Advocacy Network in 2017 and serve as the advisor. I also helped initiate the Alliance of Patient Organization in Singapore on September 2023. Next slide, please. So my outline of the sharing together with my two other colleagues will be the following. First, I will talk about SingHealth as well as our Institute for Patient Safety and Quality. We will talk about patient engagement, then go on to the ESTHER Network, the SingHealth Patient Advocacy Network, which is called SPAN, and finally, some aspect about patient partnership. Next. Overview of SingHealth. So SingHealth is one of the three clusters in Singapore, the public healthcare delivery network. We are the largest cluster. Each of our cluster has a medical school, and our medical school is the Duke NUS Medical School. Next slide. We have more than 30,000 staff, of which the majority are nursing. We have about 4,000 over medical staff as well. Next slide. So we deliver care across the full care continuum in different setting environment within Singapore. We have also the primary care network, our polyclinics, which we have more than a dozen of polyclinics within our cluster. We also have the community hospitals as well, 3 community hospitals, and as well as 5 campuses within our cluster. Next slide, please. So in terms of primary care, we have polyclinic visits in 10 locations with about 1.85 million every year. We have about 500,000 A&E visits and 2.73 million specialist outpatient clinic visits. So that is a fair bit of primary care that we are doing. Next slide. Our partnership with Duke NUS forms the SingHealth DUNS Academic Medical Center. In this medical center, we have 15 academic clinical programs or academic departments, 16 disease centers, and 19 joint institutes. Next slide. One of the institutes is the SingHealth DUNS Institute for Patient Safety and Quality. Next slide. So this institute, which I'm the group director, was launched in 2017. It was officiated by Professor Victor Dow, President of the National Academy of Medicine in USA. Next slide, please. The purpose of the institute was to embed a strong patient safety and quality culture, as well as to adopt an integrated system with the view of target zero harm and improving patients' life. Next slide, please. So target zero harm is our motto within our cluster. And there's a very strong leadership commitment to zero harm. Next slide, please. So as you know, in healthcare aims, there are quadruple of them. One of the most important on the four is that having a good patient experience, giving our patients good patient experience, trusting relationship, and good communication. Next slide, please. In WHO, of which I went to as an expert, in 2023, we have a global conference on engaging patients for patient safety. Next. Because if it's not safe, then it is not care. And one of the things about safety is that the need to engage the patient. So within the Global Patient Safety Action Plan, of which we launched sometime in 2021, one of the key strategy objectives is patient and family engagement. Next slide, please. So as you can see here, there are 7 strategy objectives. Number 4 is relates to the patient. Next slide, please. So what are these strategy objectives? It's basically the co-development of policy and programs with the patient and learning from the patient experience. Another very important aspect is having patient advocates and patient safety champions, besides giving good information education and good information disclosure to the victims when incidents happen. Next slide, please. In SingHealth, we ask ourselves this question: what is it that our patient wants? What does our patient want? Want out of the system. So what is it? Next slide. Actually, what our patient want is actually what we want. So we actually should be thinking about for the patients. And the motto within SingHealth is this: patients at the heart of all we do. So the key strategy is to engage patients and caregivers as a key partners, and it forms part of our organization strategic work plan to build a compelling vision for patient partnership. Next slide. So as you can see here, I mentioned about culture. There are many cultures we need to be able to enhance in order to have a strong patient safety and quality ecosystem. If you can see here, patient engagement and partnership culture is one of them that we must develop so that we can have a strong system while reducing other counter cultures like blame culture, hierarchical culture, paternalistic culture, among others. Next. So Wilson also in the past century or so, he says that a good physician treats the disease, but a great physician treats the patient or the person who has the disease. So that actually forms the basis of patient and person-centric care. However, we are going beyond that. We want to be able to create a patient partnership culture. Not only we treat the patient as a person, but we treat them as a partner in care. So this is what we want to go beyond in order to improve the healthcare quality. Next slide, please. Patients and family can help us in many ways to improve patient safety. For example, they can help in detecting and reporting near misses and adverse events. They can also participate in programs that educate patients about safety hazards. Next slide. And very important, if they are activated, they can take an active role in patient safety and be involved in driving efforts to improve the culture of safety. So that is the third step, the very high step, the ultimate step that they can actually help us, basically to co-create initiatives and solutions to improve care. Next slide, please. So that's why in various healthcare organizations, and especially within SingHealth, we support strongly these various groups. Number one, the patient support groups, right? The patient-centered care entities, where we try to to have the philosophy of person-centered care. We train coaches to drive improvement work to better serve the patients and to facilitate person-centered work improvement, as well as having patient-partnered care entities, like, for example, the Patient Family Advocacy Council, or in SingHealth, we call it the SingHealth Patient Advocacy Network. Next slide, please. It's very important to be able to differentiate the patients. Some patients are at low level activation. Some patients are at very high level of activation. It's our duty to increase their level of activation and also to work at their corresponding level of activation to ensure that there is optimal patient engagement and partnership. Next slide, please. So if you can see here in this so-called normal distribution, right? A, B, and C, right? A are the one with very high activation level. C, low activation level. The majority, is in between, the normal activation level, level 2 and level 3 itself. So in order to be able to engage them, we need to look at this particular level. What do you do for A? What do you do for B? And what do you do for C? Next slide, please. So for A, who are highly activated, we will engage them as patient advocates. Some of them, with the community, be in our council and committees to be able to co-develop things. For C, who are very poorly activated, they have high medical and high social needs, and this is where we have which we will present later on, the ESTHER Network. We provide this care for them and make sure that they are able to be engaged in the care actively. For the majority, as we always do, the general patient, we get them into support groups. We encourage them to give feedback, to prompts and prams, and to be able to empower them. So different strokes for different folks. Next slide, please. So our objective here is to move from disease in care to person in care to partners in care, especially for those with very high activation level. And in doing so, we increase safety and quality, patient activation, increase sharing of power, and of course, improve their care. Next slide, please. Okay, we will now have Joy Tan to talk about the ESTHER Network. Joy, please.
Thanks, Prof. Tan. Today, I represent the ESTHER Network Singapore, where I'm the current head of this network. Okay, next slide. So just a bit of background. The ESTHER Network started in Jönköping, Sweden in 1997. And who is this ESTHER that I keep mentioning about? So in our layman terms, ESTHER is actually a patient, or in the context of ESTHER Network, ESTHER is a symbolic 88-year-old lady with complex care needs requiring coordination of 2 or more care providers to address her health and social needs. So much like the Swedish ESTHER, we have our very own Madam Teo in Singapore context that you actually see on the second picture on the right side. So Madam Teo, that's actually her surname, Madam Teo, with her husband, Mr. Chang. So in ESTHER Network, ESTHER can be a patient, a caregiver, or a resident receiving health or social care services. Next slide, please. So allow me to introduce Madam Teo a little bit more. Madam Teo is 82 years old, and she has been our ESTHER ambassador since the network started back in 2016. And Madam Teo is a real patient, and she is also a main caregiver for her husband, Mr. Chang, that you see in this picture. Madam Teo has multiple health conditions, and she undergoes dialysis 3 times a week. She has had a total knee replacement done, and she sees multiple care providers. Okay, next. But what really matters to her? And this was what she told us. All I want to do is actually to stay well so that I can care for my husband. Next. So what if our care plans actually started with what matters to Madam Teo? Because most of the time as patients, what matters is not what exercise I need to do, where is the center that I need to go to, but rather at the end of the day, when I go for this, what is it that really matters to me? Okay, next slide, please. So the personas that you see over here are some of the ESTHERs or some of the patients that might actually present to you in your clinics, or that you might actually see as a healthcare professional or as a doctor. Next. And arising from this, SingHealth actually launched the ESTHER Network Singapore because they realized that we actually need a person-centered approach as well as co-producing the interventions with the patients so that we actually get a much better outcome. And one of the key ways that we do that is to actually train a pipeline of ESTHER coaches. And who are these ESTHER coaches? These ESTHER coaches are actually people who work the closest with our patients. So they can be a nurse, they can be a doctor, they can be a healthcare coordinator, they can even be a volunteer coordinator or even a caregiver to actually drive the person-centered improvement so that we can allow our patients and their caregivers to live confidently and independently in the community. Next. Next, yeah. Okay, so this has been our journey and milestone since 2016. And till date, over 9 years of working with our ESTHER ambassadors and ESTHERs, we have actually completed almost 165 ESTHER projects and worked with 65 cross-sector partners. And to date, over 400 ESTHER coaches have been trained, and they have actually gone on to lead all these person-centered improvements and spread and scale what they have done during their ESTHER coach training. Next. So at ESTHER Network, the shift that we are looking at is really building care around what matters. Over here on the left side, what you see is the patient in the center. And a lot of times when we take a look at this picture, we often think that this might be what person-centered care means, meaning that the patient is in the center. But actually, if you take a look closer, you realize that the patient might be in the center with many care providers providing care to the patient or doing things for the patient. But sometimes you realize that the care might be very fragmented, having people do a lot of things to them or for them. But what we're trying to do at ESTHER Network is really to shift the patient from the center to being an equal partner. And when we mean equal partner, we're not saying that they have the same information that we have as a healthcare professional, but they contribute the part that they are best at, their lives and the various social settings that they come from, so that we can allow what we are trying to work with them to work well. And when we actually do that, we're actually moving towards shared decision making, and we are actually trying to do things with them or even having things done by them. So by starting actually with what matters to the patient, we're actually looking at co-designing solutions and making shared decision-making routine across settings. Next. So in a nutshell, the ESTHER person-centered improvement approach starts first with the ESTHER, where you actually see at the top. So what we do is that we actually have this thing called an ESTHER cafe, where we literally meet them over coffee and tea. And we actually start with what matters to them. Next. So starting with what matters, we actually start to talk to the ESTHER to understand a bit more about what are the challenges that they might face and what are the things that really matter to them. Next. Following which, the ESTHER coaches, who are those who actually work closest with these ESTHERs or patients, they actually co-create solutions with the ESTHER. And during the course of their ESTHER coach training, they actually solve some of the pertinent problems that they have seen day to day in their clinics or even in their practice. And that's when they actually come up with an ESTHER initiative. And after they have actually done this initiative and actually tried to see whether it works, they will actually incorporate it into their work processes and look at spreading and scaling up. And what is actually important in this model is that the ESTHER coaches are supported by their sponsors, by their supervisors, and also by infrastructures as well as the leadership to allow them to be able to carry forward the person-centered improvement. And at ESTHER Network itself, it is actually a platform where health and social partners come together to actually provide end-to-end improvement so that the patients do not fall through the crack. Next. So these are some of the other ways that we actually spread person-centered care, be it through training, education, or even engagement with our com partners. And we also share the person-centered care improvements at various platforms so that we can actually find partners who want to actually spread and scale these projects further, and so that more and more ESTHERs can actually benefit from these initiatives. Okay, next. So allow me to share a few simple projects that our ESTHER coaches have actually partnered with our ESTHERs to see how we can actually put person-centric care in action. Okay, next. So in the first project shown here on empowering patients, we started with asking the patient what actually matters to them when they see a doctor. So only 57% of the patient actually feel that they have received explanation on the diagnosis, on the options for treatment, or even the management of their conditions. So when we actually asked them further, they actually mentioned that they were not sure what to ask the doctor, they were not sure where to look for health information, and they also felt that available resources are not easily visible in the clinic. So one of the proposed solutions that came up from this, they actually developed a chatbot, and this was done by our National Neuroscience Institute colleagues. So they actually leveraged on the chatbot to help to provide more information to our patients so that they knew what to prepare for their session. Okay, next. So with that, NNI actually, the coach that came for the training actually did up this simple chatbot, and they actually used it to prepare the patients and share with them how to actually start a conversation with their doctors. In fact, they wrote down 3 simple tips that the patients can do to prepare for their consultation. Simple things like writing down the questions before the appointment, or even clarifying any thoughts that they might have. And they actually link up the common conditions and treatments that they might be going through. Okay, next. And this second project that actually aimed to empower self-care in optimizing asthma control in primary care or in our polyclinics. Through the ESTHER Cafe, we realized that what matters to patients is actually to have a better control of their asthma condition, as well as to be equipped with some of the asthma control measures. So during this project, they actually realized that by having asthma counseling sessions in a person-centered model, or even having a follow-up phone call 2 to 3 weeks after the counseling session, as well as simple posters to improve the participants' awareness, actually help to improve the control of their asthma. So by doing a very simple A4 size poster on what are some of the symptoms that the patients needed to observe, the patients really felt that they were able to better control their asthma. And in fact, by having the poster in 4 different languages, they realized they were able to actually reach the patients, and the patients were able to understand the early signs of asthma attacks. And although it looked like a simple initiative, that was really what ESTHER wanted, by actually knowing what are the key things that they should be looking out for. And with this, the polyclinic has actually looked at spreading the use of these posters across the various polyclinics, because asthma is a common condition that they usually see in the polyclinics as well. Okay, next. In this next project, what they actually worked on was actually to increase the knowledge of patients on the panel blood test results from 20% to 80%. So when they actually started speaking to patients and understanding what matters to them, they realized that 80% of the patients actually understand the purpose of having regular panel test follow-up. But only 20% actually understand their fasting, target fasting glucose. And 0% of the patients actually understand what is their target HbA1c. And 0% of the patients actually understand what was their target total cholesterol, or their HDLs, or their LDL values. So what the patient requested was actually for a simpler explanation of their blood test results. And they actually felt that they had difficulty retaining the medical information shared during the session due to the stress of the outcome of the panel test results. And they felt that it was challenging to actually remember everything discussed during the short consultation time. So what actually mattered to the staff as well was that they felt that there was a lack of resources in helping patients understand the blood test results, or even in explaining the blood test results to them. So due to the limited time constraints, they felt that that was also a challenge that prevented them from explaining or providing the counseling in a very concise way, or even in a very clear way to the patients. Okay, next. So from this, the intervention that they did was quite a simple one, to actually create a visual explanation tool and standardize the education materials. And in the second phase of the implementation, they actually trained the staff how to share the education slides with the care managers to provide the patient education. And from this very simple intervention, they actually managed to raise the understanding from 80% to 100% of the purpose of the regular blood test. And in fact, at least 73% of the patients actually understand what were their target HbA1c. And from 0%, they also increased to 50% of patients who actually understood their target cholesterol levels. So one other thing that the patient mentioned was that they actually prefer physical copies of the explanation. And this was especially so for the elderly patients, because they tend to forget the explanation right after the clinic visit. And the patients actually felt that a very simple multilingual education slide would be advantageous and sufficient. In fact, sometimes as healthcare providers, myself included, we would like to stuff a lot of information into a brochure, thinking that we are actually doing them good. But a lot of times you realize that to the patients, only a few things matter, and they can, most of the time, only remember a few things. Yeah, so the participants actually expressed that they prefer visual learning, and they remarked that the explanation slides were actually informative enough to help them gain a better understanding. So the future plans to scale up were actually to provide brochures with simplified explanation of the blood test, as well as some of the targets that they should be hitting. Yeah. Okay, next slide, please. So in this next initiative called Care Compass, it's actually on this topic of advanced care planning. So a lot of times, many elderly residents and families find discussions about dying and death challenging and intimidating. So it often leads to very superficial conversations and oftentimes incomplete advanced care plans that are completed. So when we actually spoke to ESTHERs or the patients, we realized that what matters most to them is the ability to voice their values and their preferences comfortably. And they actually wanted something that was guided, because they really did not know how to start talking about this topic. And one of the top root causes for the barriers was actually a lack of conversation starters. So what you see over here in the pictures here are actually conversation cards. And these conversation cards were actually co-produced or actually suggested by our patients, because we asked them how would we be able to make this information more easily understood by them. And this was what they came up with. And in fact, with these simple cards, and now we are in the revised version, we're actually trying to make cards that are slightly bigger so that even the elderly patients are able to use them. We have actually achieved 100% ACP completion in the groups that were piloting this. And in fact, for a Malay patient, for a Malay coordinator, she was able to complete the ACP to a Chinese patient because of these cards. Because on the card, there were all three languages, and we're trying to expand it to the fourth, which is to include the Tamil language in the card as well. And in fact, from these cards itself, the ESTHER actually told us, I actually never expected ACP to be cheerful and enjoyable. And the cards actually helped them to start the conversation early and easily. And one of the patients, who was a male patient, he actually mentioned, as an ego-driven person, the cards boosted my confidence in expressing my values and preferences. So as a scale up, we're actually trying to introduce the cards to SingHealth place-based care teams, and potentially spreading to our community partners, so that they can actually use this card to discuss ACP plans with their patients and clients. Okay, next. And in this final project by one of our ESTHER coaches who graduated in 2024, it was actually on co-developing health goals with residents in the community. So Jill that you see here, she's actually a community nurse and she visits her patients in the community in their homes. Okay, next. So oftentimes we realize that healthcare goals are usually determined by healthcare providers. And we realize that this paternalistic approach often results in poor ownership of health when we are told to do this, to eat this medicine, to do this exercise, or maybe do this 3 times a day, 10 times by 10 seconds. So next. When Jill actually visited Mr. Ho that you see here in the picture, she actually realized that when she started asking Mr. Ho to achieve a better HbA1c or to have better blood pressure control or to have better blood glucose levels, initially she was always met with, okay, I'll try. But when she actually visited Mr. Ho, she actually realized that it's not that Mr. Ho did not want to choose healthier food options. But because Mr. Ho was a stroke survivor and he moved around in the community on an electric wheelchair, we realized that he could only get to the stalls at the side of the hawker center. And those 2 stalls were the stalls that actually sold fried bee hoon or chicken rice, which were the not so healthy options. So when we actually invited Mr. Ho to be included in the conversation, we realized that the real barriers to adherence or even to achieving the goals became visible or became audible because he started speaking and really telling us what was the real barrier. And the care actually shifted from being one-sided informing to shared care. And lastly, what matters to Jill, who was the comm nurse, and what matters to Mr. Ho, which was actually having more care options, were then met meaningfully. Okay, next. So following which, Jill actually started this very simple health goal board where she actually discussed with her patients what were the goals that they wanted to achieve. And I think one of the key things that spoke to us was that rather than choose 3 or 4 goals to reach with them, start off with just one so that is at least doable. And they actually allowed the patient to draw on the health goal board on their own because some of these residents actually do not read very well, or they might not be able to read. So when they're able to draw out or write their own goals, it's something that they understood and it's something that is tailored to their level of understanding and literacy. Okay, next. So as a result, we realized that by this simple health goal chart, they actually managed to improve the self-rated health questionnaire by 100%, and the goal attainment was actually 88%. And some of you might ask me, how come it's not 100%? Because actually some of these patients do have health events or deterioration, such as like maybe they might have a fall and requiring them to review their goals or reset their goals. And one of the key enabler was that the goals actually made the health goal board made the goals visible, shared, and it was something doable for them. And as part of the scaling up, we actually integrated it into the communication board that was shared by the community nurses as well as the community partners seeing Mr. Ho. Okay, next. So this is one slide, sorry. So this is one key motif that we're actually moving towards, where we're actually able to move away from doing things to the patient or for them, but actually to partner with them or to even have things done by them. Okay, next, please. So over 9 years of ESTHER Network, where we actually partnered with our coaches, our ESTHER ambassadors, our patients, their caregivers, we realized that there were 8 key domains of concerns that they really wanted our healthcare providers to get right. And of which you can see over here, they actually wanted accessible care. They wanted care that was integrated, not having to go to like maybe 8 or 9, 10 different healthcare providers to get one thing sorted out. And they really wanted to be able to live in a community, to stay well and to be comfortable in the community, or even to be able to be activated or even empowered. And of course, they also mentioned that they wanted healthcare communication to be clear, compassionate, as well as giving them sufficient information so that they can be involved. And that is where you actually see that this portion on goal setting comes in, because they really wanted to take charge of their life. Yeah. Okay, next. So this simple stack chart actually shows us the project trends over 9 years, where living in the community remains as one of the key high focus areas. And there's actually a consistent focus on patient involvement. And they do want to be involved. And we realize that by involving them, we actually do get better outcomes. And over the years, there is actually greater cross-sector coordination with the patients coming in more strongly. Next. So ultimately, what is best for Esther or for our patient is to always ask ourselves what matters to our patients and to let the answer guide our subsequent actions and our improvement work. Okay, next. And we often encourage our healthcare team to start not with a diagnosis, but with a conversation, especially to the patients that you might find that have complex condition and who might struggle with self-management, on what really matters to them and how we can make that doable for them. Yeah, next. So with that, thank you. Yeah, I'll pass on to Ellie. Yeah.
Thank you. Thank you very much, Joy. I just would like to follow on with the last words that were uttered by Joy, what matters to the patient. So a lot of the work that we do in SPAN is centered around what matters to the patient and how we elevate this to the healthcare professional. So good evening, everyone. My name is Elil, and I have been working with SPAN since 2017. Right now, I'm one of the mentors, and I'll be co-chair again in September. Right, next slide, please. So this is one of the publicity posters to recruit members to join SPAN. And really, it all started with a support group. When you're a member of a support group, it means a lot to meet others who are going through the same challenges as you. And it's from these support groups that I went on to get involved in SPAN through the nurse clinician who recommended me, and that is Sister Ong, who is a APN, colorectal nurse. Next, please. So basically, SPAN is actually a PFAC, which is a Patient and Family Advisory Council. But here we call it we call ourselves advocates, and we're called SingHealth Patient Advocacy Network. Right? And it's a self-driven network of volunteer patients and family advocates who represent the collective voice of patients. Next, please. So it all started actually sometime before 2017, where we had focus group discussions, right? So we had 5 or so focus group discussions and invited patients and caregivers to discuss a number of topics during these focus group discussions. I remember very clearly Prof. Tan was the one who usually led these meetings. And it was a very cozy affair, right? Next slide. So now it is in its current format. As you can see, I'm one of the mentors, and we have the 2 co-chairs. Both of them are caregivers. We also have core team members who take on and lead work streams, right? Like education and engagement of SPAN members. And our advisors are from the domains in SingHealth and the domain leaders like Prof. Tan himself, Dr. Tracy Carol Air, who is our group chief nurse, and Ms. Audrey Lau, who is our group chief communication officer. Next slide. Right. So basically, it is about empowered patients at the heart of quality healthcare. We are also guided by the same core values of SingHealth itself, which is compassion, integrity, and collaboration, right? So we want to empower patients. We want to make sure that the professionals are engaged, and this together will lead to enhanced care. Next slide. Right, so what Prof. Tan had alluded to earlier, that we want to move on from just being a patient to a partner in care. So that is basically our overall vision for SPAN, right? So we actually scaled up from one cluster span to about 8 now, including the spans at the various institutions under SingHealth. And then we partner healthcare staff. We have 2 flagship programs and 7,000 over staff actually impacted. All right. And we have done over 300 projects, combined total of the cluster level and the institution. And basically, we want to make sure that we amplify the patient's voice. And we do it in several ways, not only within a clinical setting, but also in a patient community setting where we organize events enabling both patients, caregivers, and healthcare providers to come together to share best practices. And I'll talk a bit more about such events later on. Next. Right. So what do we look for in a patient advocate? So the acronym IMPACT sums this up perfectly. Basically, you want someone who is insightful, who is motivated, willing to listen, passionate about improving the healthcare landscape, is able to adapt and go beyond personal experience and take a step back and see the big picture, right? Someone who is confident and comfortable speaking up in a group and interacts well with people as well. And most importantly, to be a team player. Right. So, yeah, this acronym is a wonderful way to remember the qualities that we look for in a patient advocate. Next slide, please. Right. When we started, we really had to build awareness about patient advocacy. It wasn't something that was embraced at once by the healthcare professionals. Some of them were even very cautious, right? Some of them looked at us as troublemakers, right? Trying to tell them what to do or how to do their job. So we had to build awareness, and we did this through several touch points. You've heard of TED Talks. We have our PACS Talks, right? PACS for patient experience at SingHealth as well as the institutions. And we collaborated with others as well, all right, to spread the message about getting patients involved to improve outcomes all around. Next, please. So basically, we also needed to empower the patient advocates. And then we do this in a number of ways. One of them is to guide them through sort of a workshop, which we call PFPC, which stands for Patient and Families as Partners in Care. Right? So we have done about 9 of these workshops since 2020, and 61 new advocates have actually attended. And all those who attended felt confident that this was relevant to their advocacy work. All right? And apart from just onboarding patients and caregivers to be advocates, we also run a module of the course for senior nursing leaders. Right, we call it the Best Patient Experience. This course was curated by SPAN and is run by SPAN facilitators. All right, and this is an excellent example of how SPAN advocates can actually go a step further instead of just simply elevating their voice, but also get involved in education of healthcare professionals and really put across what is important or what matters to the patient, which is similar to what the ESTHER Network does as well. Next, please. Right. And one of the things we really advocate is to healthcare partners is don't start a project and they, at the end of it, come and ask the patient partner whether it's something that can work. Because by the time it's too late, too much time and effort has been invested in it to try and change anything. So we encourage them to get SPAN involved in a very early stage, as early as the planning and design stage, right? And then to carry on involving them in the implementation and review stage, so that all along the way you can ensure that the project is patient-centric, right? Because what matters most is the patients, and patients are at the heart of everything that SingHealth does, and that is their tagline, right? Next slide, please. For me, one of the most important project that we have done in SPAN is the plain English glossary. More often than not, when patients and their families visit healthcare institutions and then they are given information by either the nurse or the doctor, and because the nurse and the doctor are all task-orientated, and they may not have the time to really spend a longer period of time explaining things, they tend to fall back to their medical jargon when explaining things. And such words may not make sense to the patient or the family member, right? So things like ambulate, right? A very few lay people will know what ambulate is. The moment you say ambulate, they think of an ambulance, right? And to be fair to the healthcare workers, again, they're task-oriented, they have a heavy workload. They may not have the luxury of time to think over these things carefully. So what we did is we came up with a glossary of plain English words which can substitute this medical jargon so that they have a ready reference, all right? They don't have to crack their head to think of a word that can be understood by a patient and caregiver. So we started off with 150 commonly used words. We're going to expand this, and we also have plans to maybe translate this to other languages. And this particular project was also featured in our Chinese language mainstream newspaper. Next, please. Right, and the other project that was more recently concluded is the COMED Guru, or Co-Management of Medication in the Community, ground-up scale, okay? COMED Gurus for short. And this is basically a cluster initiative whose main goal was to improve the medication adherence of the patients in the community. And as a sub-goal was to improve the medication literacy of patients. All right, so the project team was a multidisciplinary one made up of doctors, pharmacists, community nurses from CGH, and some of the other hospitals in the cluster. Next, please. Oh, sorry, previous slide again. Yeah, so this was basically targeted at the elderly who were living alone, who had cognitive and mental conditions and required assistance to manage their medications. All right, next slide. So we also work with the primary care networks, and we actually had focus group discussions where we discussed vaccination rates, reduction in smoking cessation, as well as the diabetic foot screening, retinal photography, and the blood tests. All right, so this particular engagement involved the general practitioners, the specialists in epidemiology, preventive medicine, endocrinology, and family medicine, as well as nurses and primary care coordinators and administrators, and 3 patient advocates. So it was well represented to ensure that all angles or all aspects of care were actually examined during the project. Next, please. We also work with the healthcare teams to co-design safety and experience with for example, the emergency medicine building that has just been built. So patient advocates were involved from the very beginning, looking at prototypes. You see, we even requested for a wheelchair when we were asked to do a walkthrough, because what we see as standing, walking tall is different from what a wheelchair users sees. All right, access to buttons that you need to press and stuff like that, or going through doors. So we do such things when we engage with the healthcare teams to make sure that they are on the right track and they are inclusive when it comes to looking after the needs of patients. And especially when they're building a new building, they want to start on the right foot and not leave out groups of people that are not able-bodied, as well as, again, to understand what really matters to the patient and how they can make the healthcare experience a pleasant one for not only patients, but also their families. Next. We deal with the present, and another project that actually deals with what is going to happen in the future is to create the future patient journey. So we have a new hospital coming up, and SPAN advocates were actually engaged in focus group discussions to help the planners, the healthcare professionals, to envision what the future patient journey is going to look like, so that when they actually build and staff and equip the hospital. They can take all this input into consideration. Next. The patient bedside tablet is another initiative which is quite innovative, and basically it is to take the load off the nurses and also make things easier for the patient. The tablet, through the tablet, the patient can actually order the things that he wants so that the nurse doesn't have to come running every time the patient presses the call bell. Right? You can also see the care plan, the care team, and other information. Right? Next, please. Right, and okay, so again, patient perspective in digital healthcare. We SPAN advocates are also involved in this. And next one. The MOH also found that SPAN has got a ready group of patient and caregiver advocates when they want to get inputs on education material they want to release to the public. So we are one of the first stops where they run the education material by us and find out whether it's too technical, easy to understand, well laid out, and so on. And they really take our feedback on board and make the changes so that when they actually roll it out to the public, it is a useful piece of material. Next, please. Yeah. So basically, as I explained earlier, we have engaged in more than 300 projects. Next slide. And we also share our experience, like in this webinar, both locally and globally, collaborating with various institutions. Next. And we have written a paper on how we can initiate and sustain a patient advocacy group like SPAN. Next slide. The next slide, please. All right, and this is the paper that was published in the Journal of the Institute of Patient Safety and Quality. This is so that we can document whatever we have done and others can actually follow the example and not reinvent the wheel. Next slide, please. Right, so we want to make sure there's patient engagement across the continuum of care. Next slide. And we want to build sustainable partnerships between the patients, caregivers, and the healthcare fraternity. Next. Right. So that is all I have for SPAN. I shall hand over the time back to Prof. Tan.
Yeah, thanks, Elliot. In view of time, I just have two more slides to just end. Maybe, yeah. Firstly, is that patient advocacy education as well as teaching our staff about patient experience is important and is part of our training continuing education program. Next. I'd just like to end by saying that in our master's program and our graduate programs, patient experience and engagement is a very important module that includes open disclosure, managing clinical incident management, supporting PROMs and PREM, and supporting the patient care center and patient partnership networks. So thank you very much. I think we will end here. This is what we have. We appreciate if there's any questions that you want to ask us. Thank you very much. We can go to the gallery mode. Yeah. Thank you.
Thank you very much for your presentation. It's been a tour de force in relation to patient engagement and patient advocacy. We have a few minutes for questions and answers. And I would please feel free to write your questions in the chat if you prefer, and I will read them for you. And also just raise your hand and I will also give you the floor if you have any question that you would like to pose. Well, I will give you 1 or 2 minutes also to think about those questions. And so perhaps from me, sorry, we have a question from Ye Wang. Yes,
Hello.
please go ahead.
Hello, thank you all very much for the excellent and inspiring presentations. I'm Dr. Wang from the patient safety team at Chongqing Medical University in China. I saw lots of Chinese word and also some Chinese patient as examples, so I feel very happy to to express my ideas. And in our team, actually, many activities are carried out with teachers, which are doctors and nurses, guiding medical students to work together to help patients in the community. So that is our model. So, and my question is that we always worry about when the students interact directly with patients. We're always concerned about the risk of unintended or secondary harm. Like, for example, even after training, their words or behaviors might affect patients, such as giving answers that are not professional or accurate. So from your experience, how can we better safeguard patients while still enabling students to participate in this kind of activities? So thank you very much.
Our program basically involves the whole range of healthcare workers. In fact, for example, like our SPAN and it's actually new in a sense because we only adopted it for the last few years. Our own healthcare staff, those more senior ones, they are not actually exposed to this as well. So we are starting with them as well. In our medical school as well, this is a new topic. In fact, patient safety and quality is a new topic. So if they are medical students, they would probably know how to, have good quality care, of which patient-centeredness is one of them. But we don't actually involve them. Although in the module of, community care, there's module on social and community care, they are usually advised by the tutors to make projects, and the students can actually form projects to see how they can, improve community care, and they have to do a write-up about it itself. So I don't think it's a problem in terms of that. It is a problem of getting the time for them to be involved. For the student, it's more that they have many things to learn, right? So it's the time exposure that we can give to them that I'm more concerned about rather than the risk to the patient. In fact, most of the community patients are very happy to have people to talk to them. Actually, they love students to talk to them. Thanks.
Thank you very much. Thank you.
Thank you so much. Do we have any other questions? Any hands? Any? So I think that one of the issue that probably people may be more intrigued, I presume, is actually the people interacting directly with patients in order to retrieve their engagement, to ensure their engagement. They need, we know as family physicians how important these individual relationships are. So how to build trust to ensure that patients are confident in open up and engaging. So I wonder if you could share information with us how what efforts you made to ensure that you could keep all the team tight and ensure that there was a sustainability of the efforts, because I presume that every time that you need to bring someone anew, that will also have some cost in terms of training, but also of patient engagement.
Joy, you wanted to answer this question about how to sustain ESTHER, and I think for ESTHER, because our ESTHER patients are generally not so well activated, and we're trying to move them, trying to increase their activation level, and sometimes by providing coaches to them, their activation level goes way up itself. So that itself will create the trust, right? So I don't think it's an issue. If patients have suffered adverse outcome, we have open disclosure. That's part of the feedback itself. And for patients who have gone beyond their adverse outcome, right? And they can actually become patient advocates. So some of them wanted to contribute back to that. So basically different strokes for different folks. When we create trust, we have to look at the situation. But Joy may want to talk about the fact that whether it's sustainable and how to continue with that. Yeah.
Thanks, Prof. Tan, and thanks, Prof. Josie. So, in ESTHER Network, the coaches, they have specific areas that they work in, and thus far it's been sustainable because when we actually engage the patient in the project, and when the patients are engaged from start to end, and they see that the project's results are being shared, and how it actually makes a change in the healthcare itself, actually the patients are even more motivated to give back. In fact, recently we have quite a few of our ESTHER ambassadors who actually requested to join us for all our trainings and to share their experiences throughout the training itself. And in fact, when they actually hear the feedback of how they are sharing during the ESTHER Cafe, or their feedback, how it actually changes even the healthcare provider's lens, I think it was very powerful, because even the ESTHER themselves, she was on the verge of tears, because she actually realized that, actually there are people who are interested in my story, and that my story can help to provide insight to healthcare providers. And I think that realization comes when the patient and the healthcare providers both realize that we both want to do better. And when the patient actually realized that the provider did not intentionally not explain the findings to me, but it might be because they do not know that this is a blind spot to me. So when they actually realize from the patient's point of view, they actually realize that that is where we can come to equal partnership or even shared decision making. Yeah, so when it is sustainable in the sense that for those implemented solutions, we have actually attempted to scale up across teams and across sectors. So that has been helpful, and the ESTHERs themselves actually recruited, so-called, by the coach themselves, and they meet these patients day in, day out in their practice. So they actually volunteer the time and experiences. Yeah, thank you.
Thank you very much for your response. Unfortunately, we don't have time for more. I would like to thank you on behalf of the whole of WONCA and the WONCA Working Party for contributing your time and efforts. And also, I would like also if just ask very briefly if people with camera would like just to open it up now so that we can see. Just to show our appreciation to the speakers, and also we'll take a picture of that, so to show that there were plenty of us around this virtual table. So I will take more time. Thank you all for joining, and particularly thank you the speakers for your excellent work and excellent delivery. This has been recorded and will be available for future revision in the near future. We will share the details with you. Thank you so much.
Thank you.
And have a good day. Bye-bye.